Are you looking to sharpen your intraoperative decision-making during mitral valve repair surgeries? In episode 13 of Tea Time, we'll be assessing repair versus replacement decision-making, types of repair strategies, and even evaluating mitral valve repair post-bypass. This will be all of the must-know content when performing TEE for mitral valve repair surgery. Welcome to Tea Time. I'm Dr. Andreas Plackis, and in this episode, episode 13, we're going to be talking about TEE for mitral valve repair surgeries. The clinical question we're going to address today is how can a clinician use TEE to provide best care for patients undergoing mitral valve repair surgery? A few of the topics that we're going to review in this episode of Tea Time are number one, repair versus replacement evaluation, when each one is indicated. Number two, the pre-bypass TEE assessment of mitral regurgitation. Number three is goals, types, and principles of repair. And then four, we'll round it out with the post-bypass TEE assessment of mitral valve repair. Why are we even talking about mitral valve repair when we've discussed mitral valve replacement surgery in the prior episode? There's a few advantages to mitral valve repair. These include that repair will preserve native valve functional components. There is better postoperative ventricular function. It avoids the complications that can occur from prosthetic heart valves, and there's lower associated operative mortality with repair surgery. However, with replacement, a good replacement is preferable to a poor repair and can be more durable in some circumstances. Some of the circumstances and factors that can influence repairability are seen here in the slide. These would include the lesion location. Is it a small area that's localized of prolapse, or is it diffuse disease? How is the leaflet quality or calcification? Is there annular dilation or calcification? What is the quality of the subvalvular apparatus? What is the mechanism of MR, and is it one that is frequently amenable to repair or not? What surgical factors may influence a surgeon to perform repair versus replacement? And then a big factor is surgeon expertise and experience. Is a surgeon even comfortable performing certain types of repair, or are they one that may favor replacing valves because they're less comfortable performing more advanced mitral valve repair surgery? There's a good table that rounds out a lot of these considerations, and it is worth remembering that these are not black and white considerations. Really, we're going to try and remember what components favor a successful repair and what components may lead to an unsuccessful repair that would push us towards wanting to replace a valve. Let's look at exactly what some of those factors are that would make us favor repair or favor replacement. So, first factor favoring repair is posterior leaflet lesions less than 1/2 of the leaflet. Also, some things that are frequently amenable to repair are prolapsed or flail lesions. Pure annular dilation is also frequently amenable to repair, such as in those dilated annulus from atrial functional MR. Some of the factors that would push a surgical team towards replacing a valve are when you have severe leaflet or annular calcification. Severe MAC is very complicating for mitral valve surgery in general, but especially makes it difficult to perform a successful repair with poor quality leaflets. If those leaflets are also thickened or retracted, it would push towards replacement. Infective endocarditis, complete papillary muscle rupture will also favor mitral valve replacement surgery. And then when looking at secondary ischemic MR, there are certain things you can measure as an echocardiographer that would indicate whether a successful repair is likely or an unsuccessful repair is likely. Factors associated with repair failure include tenting of greater than 1 centimeter, tenting area greater than 2.5 centimeters, a very dilated LV with an LV end diastolic diameter greater than 65 millimeters, or a P3 tenting angle greater than 29 degrees. Frequently, there's asymmetric tenting that can occur, and especially at that P3 site, if there's extreme tenting greater than 29 degrees, that is one independent predictor of mitral valve repair failure that would push a surgical team towards replacing the valve. Let's focus next on the pre-bypass period of mitral valve repair surgery. There are three major goals we will want to accomplish in the pre-bypass period. The first of which is evaluating the mitral regurgitation and assessing the mechanism, location, and severity of the lesion, and also assessing feasibility of repair, whether the lesion is amenable to repair or a replacement would be favored instead. The second goal is identifying other heart pathology that may need addressing at that time. This would include LV or RV dysfunction, certain other valvular disorders, and shunts that could be present in the heart. The last goal here in the pre-bypass period is identifying complicating surgical factors that may influence how you use TEE in the pre-bypass period or the post-bypass period. These complicated surgical factors can be divided into the 3 C's: chest entry, cannulation, and cardioplegia strategies. We will want to know all these things before the surgery begins. So the first pre-bypass goal, evaluating mitral regurgitation in a little bit more depth. We have covered this extensively already in episode 10 at length, and then again in episode 12 summarized how do we even evaluate mitral regurgitation succinctly. So feel free to go back to those episodes and look through this if you want a more in-depth assessment. But just to recap very briefly, we will want to determine the mechanism, location, and severity of the mitral regurgitation every time. And then as it relates to mitral valve repair surgery, we will also want to determine if the lesion is amenable to repair. As far as the mechanism, we'll want to determine what is the Carpentier class. The location, we'll want to know the exact location of the defect that's causing the mitral regurgitation. And then we'll want to use the 2017 ASC algorithm for chronic mitral regurgitation to determine the severity of the valve. Step 4 in evaluating mitral regurgitation is determining feasibility of repair. The question we're asking ourselves here is the mitral valve anatomy suitable for successful long-term repair, or would mitral valve replacement surgery be indicated instead? And also, are there significant risk factors like SAM or tenting for repair failure? Can these be mitigated, or is repair contraindicated because of these risk factors? I've mentioned my system previously and how I evaluate the mechanism and location and severity of the MR, but in brief, I get a mid-esophageal view. I'll X-plane through this right down the middle to see a long axis view, and I know the leaflets at this point are A2 and P2. I'll slide that X-plane medially to see A3 and P3, and then I'll slide it laterally to see A1 and P1, and that allows me to assess each part of the valve. I do all this with and without color, and that is my assessment for the mitral valve. If I have difficulty viewing the valve, or I need to see other parts of it, I can use 3D or other views to take different looks at the leaflets or further assess the valve. There's a few things that I want to define before going any further to make sure we are all on the same page as far as terms for mitral valve assessment. The tenting area is defined as the triangular area formed by the mitral valve annular plane and those tenting leaflets. Remember, in secondary ischemic MR, that tenting area is predictive of repair failure. Also, that tenting length is the distance from that mitral valve annular plane to the coaptation point. Tenting length greater than 1 centimeter is predictive of mitral valve repair failure in ischemic secondary MR as well. Next, let's move to the mitral valve leaflet height. You'll see this with the blue arrows here, the posterior mitral leaflet height and the anterior mitral leaflet height. And this height is always going to be shorter than the length. The height is defined as the spot from the mitral valve annulus to the coaptation point in systole. And it's measured in systole because systole is when the leaflets will coapt. However, when we move to the red lines, you'll see the mitral valve leaflet length is measured from the mitral valve annulus to the leaflet tips in diastole. Lastly, coaptation length is the length of overlap of the two leaflets. Part of the assessment of feasibility of mitral valve repair is seeing is the lesion amenable to repair, but then also trying to rule out risk factors for repair failure. And these would include SAM risk factors and secondary MR risk factors. I tried to simplify this as much as possible, but you can think about the pathophysiology of SAM as any force or factor that predisposes that anterior mitral leaflet to be drawn towards that interventricular septum. So I divide these into LV factors, specifically only LV contributors, and then factors that also involve the mitral valve. Let's start looking at the LV factors first. What qualities of the left ventricle can predispose to SAM after mitral valve repair? Well, think about this as a non-dilated, hypertrophied, and hyperdynamic ventricle. Certain things that can show up, especially on your echo boards, include LVEF greater than 65%. That's that hyperdynamic ventricle. A thick basal septum, especially if it measures greater than 1.5 centimeters. A small left ventricle as well, where you have an end systolic diameter less than 3.5 centimeters, or you have a left ventricular end diastolic diameter less than 4.5 centimeters. A non-dilated, hypertrophied, and hyperdynamic dynamic left ventricle, all predisposed to SAM after mitral valve repair. There are also factors from the mitral valve as well that contribute to SAM after mitral valve repair. The first of which is the C-sept distance. This is the coaptation septum distance measured in early systole of less than 2.5 centimeters. An aortomitral angle less than 120. I want you really to understand this just by thinking about it instead of memorizing it, because as you lower that angle, that mitral valve anterior leaflet only gets closer to that interventricular septum. Anterior leaflet length greater than 2.5 centimeters. This is because when you have redundant anterior leaflet tissue, you have a redundant amount of tissue that's more likely to flop into that left ventricular outflow tract. A posterior leaflet length greater than 1.5 centimeters. This is relevant because when you have a longer posterior leaflet, well, this can push that location of the coaptation point towards the left ventricular outflow tract. But when you have a shorter leaflet, it actually pushes that coaptation point more posteriorly away from that left ventricular outflow tract. And another way to look at this is that anterior leaflet height to posterior leaflet height ratio less than 1.3. This is just one other way that looks at how posteriorly is that coaptation point located. Going back to our terms, this is based on the heights of the anterior and posterior mitral leaflets, not the length. The other cardiac data that's relevant to assess when performing your TE assessment during these repair surgeries are assessing LV size and systolic function. The LV can dilate over time with chronic MR and volume overload. Also with function, a normal EF may not be normal if half of your flow is regurgitant flow. So keep this in mind when you come off pump after the fact, as you lose that pop-off valve and now all the flow is obligated to go forward. Also, get a baseline assessment for any regional wall motion abnormalities. These surgeries put patients at risk for injury to the left circumflex artery, so that could cause regional wall motion abnormalities post-bypass. We'll assess the left atrium and left atrial appendage. Frequently, left atrial appendages are clipped during mitral valve replacement or repair surgeries. Also, the left atrium can be significantly dilated from the chronic volume overload. We'll assess the RV size and function and for any potential pulmonary hypertension. These increased pressures in the RV seen from left-sided heart failure or left-sided elevated pressures can cause RV dilation and dysfunction and functional TR. We'll assess the baseline function of the aortic valve, as this valve is in close proximity to the mitral valve and is at risk for injury during surgery. Lastly, we'll want to assess the tricuspid valve as well. Frequently, it's recommended in these surgeries if you have even non-severe, non-symptomatic, mild or moderate TR with significant tricuspid annular dilation greater than 4 centimeters or prior right-sided heart failure symptoms. This is a class 2A recommendation for tricuspid valve intervention during the time of your mitral valve surgery. Part 3 of our pre-bypass echocardiographic assessment is looking at surgical factors. Again, these can be broken down into the 3 C's. The first C is chest entry. Knowing the chest entry is important because frequently the more minimally invasive the surgery, such as robotic or mini thoracotomy, it is more TE intensive. The second C is cannulation. Is the surgeon cannulating centrally or will it be bicaval, femorally? The last of which is the cardioplegia administration strategies. If retrograde has to be guided into that coronary sinus, or even if they're using an endo balloon, that has to be appropriately located as well. Let's turn to some of the intraprocedural things to know during these surgeries. What are the goals of mitral valve repair surgery? The ultimate goal here is valve durability. Can you fix the MR and improve the patient's symptoms 10 to 20 years or more? From the 2020 ACC/AHA Valvular Heart Disease Guidelines, mitral valve repair is recommended to replacement when the anatomic cause of MR is degenerative and a successful and durable repair is possible. Can we perform a durable repair? What are certain factors that a surgeon would consider to determine if a durable repair is possible or how to create this durable repair? Number 1 is, can they eliminate the mitral regurgitation long term? This is performed by restoring that leaflet coaptation length. The degree of overlap needs to be between 4 and 10 millimeters after the surgery. That is one of the big markers of long-term durability. 8 to 10 millimeters is even better. The surgeon will want to stabilize and remodel the annulus. That's why frequently rings or bands are used at the time of valvular surgery. The best repairs will be performed by maintaining normal leaflet motion. And there's some newer philosophies that involve respecting rather than resecting leaflet tissue tissue in order to maintain this normal leaflet motion. And I'll get into a little bit more what exactly that means, that respect versus resecting tissue. Lastly, a surgeon will do everything they can to avoid new surgical complications. And these are avoiding SAM post-repair, iatrogenic mitral stenosis, LV dysfunction from a circumflex injury. Let me talk through a few common repairs that can be performed in mitral valve repair surgery. The first of which is a triangular resection. This is indicated when you have posterior leaflet prolapse less than 1/3 of the leaflet tissue. If you have prolapse greater than 1/3 of the leaflet, well, this repair can put excessive tension on those leaflets as they're reapproximated. But essentially, a triangular wedge is excised in that prolapse segment, and then the free edges will be reapproximated and sutured back together. That is a way to resect that excessive leaflet tissue. The next type of repair that would be possible is a quadrangular resection. This type of repair is indicated if you have posterior leaflet prolapse greater than 1/3 of the leaflet. Because you're resecting significantly more of the posterior leaflet, it can move that coaptation point more posteriorly by lowering the posterior mitral leaflet height. And this can be a helpful prevention strategy in patients that have risk factors for SAM post-repair. It's performed by resecting that quadrangular portion of the mitral valve, that prolapse segment, and then reapproximating those free edges to a sutured closed repair. If that tissue gap after the quadrangular resection is extensive, such as greater than 2 centimeters, well, a sliding plasty can be added to this as well. That's because if you only tried to close that defect with sutures with a large defect, it can result in excessive tension on those leaflets and possible repair failure, or it can even kink the circumflex artery by putting too much tension around the annulus. So sliding plasty is where you can use scissors to partially detach the P1 and P3 segments from the annulus and slide those together to close those with sutures and also close the annulus. This, again, results in less leaflet tension for those large defects that require large resections. Annuloplasty rings are also frequently used in mitral valve repair surgeries. They help because they restore annular physiologic size and geometry, they can enhance leaflet coaptation, and they can also prevent further annular dilation for more durable repair surgery. How do surgeons size these rings? Well, the two main factors that determine sizing of these rings include measuring the intertrigonal distance, that is the distance at the top, horizontally left and right between the two trigones, and also the anterior mitral leaflet height. That anterior mitral leaflet height matters because a surgeon needs to allow that anterior leaflet to spread all the way out and coapt on the correct plane at the correct coaptation line without prolapsing. If the ring is sized too small, that can increase the risk of SAM because you're moving that posterior part of the annulus more anteriorly. You're closing that gap between the interventricular septum and that coaptation point. Also, if the ring's too small, there's increased risk of ring dehiscence because there could be too much tension on that annular site. If the ring is too big, well, it increases the risk of residual MR. In type 2 Carpentier lesions with excessive leaflet motion, prolapse leaflets, flail leaflets, the strategy here is sizing correctly or relative upsizing of the annulus. That's because you're trying to get a ring that matches the enlarged annulus that can accommodate a lot of that excessive leaflet tissue. However, in the Carpentier type 1 or 3B lesions, there's a dilated annulus, and that's a big reason why there's MR in the first place. So if it can be downsized with a complete annuloplasty ring, the hope is that doing so can downsize and improve the coaptation length of the valve and actually improve the MR altogether. How does a surgeon even decide what type of ring or band, flexible or rigid, partial or complete? How do they even decide what they're going to put on a valve? Well, frankly, a lot of this is based on surgeon preference. There's a few principles to remember. When deciding between a flexible and a rigid band or ring, the advantage of the flexible one is that it preserves the natural dynamic annular motion. The advantage of the rigid one is that it can restore the annulus to the natural saddle shape. When thinking between partial or complete bands or rings, the partial one can be favored in myxomatous valve disease, as it's more common that the posterior annulus is prone to dilate in these patients. So you don't need something on the anterior portion of the mitral valve as well. And the fix purely requires a stable annulus. However, a complete ring may be favored in secondary MR patients where the anterior annulus can be prone to dilate more. And to actually fix that valve pathology, a smaller annulus is needed, so a complete ring can help create that smaller downsized annulus. There's many other repair alternatives as well. It is worth mentioning the artificial chordae or neocords that can be implanted as well. This can restore mitral valve function and coaptation line with that respect is greater than resect philosophy by simply reimplanting these new cords to help keep a prolapsing segment from prolapsing or a flail segment from being flail. By pulling that tissue back down into the LV, it can restore an appropriate coaptation length without having to do significant resections of that mitral leaflet tissue. There's also several other options for leaflet repair that I won't get into as it's beyond the scope of this episode. There's lots of other options surgeons have to choose from. How do surgeons even test their repair before they come off cardiopulmonary bypass? Well, with two methods, the first of which is the saline test. They take a bulb syringe and inject saline to distend the left ventricle. This will reveal the degree of mitral valve competency if you see that fluid coming back through an incompetent mitral valve. It can also show you if the coaptation line is symmetric and appropriately located or not. This allows them to evaluate repair quality and make any corrections if needed. The second method is using the ink test. This is where you fill the left ventricle with saline, you ink at that coaptation site, and then you evaluate the coaptation line to make sure it occupies a posterior position within the mitral valve orifice. The surgeon will want to see a ratio of 3:1 of visible anterior to posterior leaflet areas. This also can help determine the depth of coaptation for each leaflet. I mentioned earlier that the goal coaptation length is 4 to 10 millimeters. This is because a coaptation length less than 4 millimeters is one indicator of early failure of the repair, and a surgeon may choose to resect secondary chordae or downsize a ring with this coaptation length too little. However, a coaptation length too much would be greater than 10 millimeters, and this predisposes patients to SAM. Something that may have to be performed here is actually upsizing the ring that was put in or performing posterior leaflet height reduction. Some of those repair principles to remember are restoring leaflet coaptation length. The goal is 8 to 10 millimeters, but greater than 4 is okay, as this is important for long-term durability. You'll also want to restore normal leaflet motion and reduce enlarged segments. Surgeons are more commonly choosing a respect over resecting leaflet tissue philosophy by performing neocords, preferentially over resections. Respect that anterior mitral leaflet. Do not perform major resections on that anterior mitral leaflet, as it needs to make up the majority of the mitral valve surface area to function correctly. For durable repairs, it's important to stabilize the annulus with some type of ring or band, and then also avoid new surgical complications to the valve, such as SAM, iatrogenic mitral stenosis, or left ventricular dysfunction. So what repair strategies will be indicated for certain leaflet pathology? If you have a small posterior prolapse, neocords, or a triangular resection. If you have a large posterior prolapse, that's where that quadrangular resection with or without sliding plasty or neocords would be indicated. If you have anterior leaflet prolapse, neocords can be a great fix here, as remember, you want to treat the body of the anterior mitral leaflet with great respect and avoid resections if possible. Bileaflet prolapse, the Barlow's valves, you can either perform neocords or multiple resections. And then in primary MR, remember this is the degenerative myxomatous fibroelastic disease, you'll have a relative upsizing of that ring to match the enlarged annulus and accommodate that excessive leaflet tissue. What repair strategies are indicated in secondary mitral regurgitation? For atrial MR, a downsized annuloplasty ring may be all you need, as the pathology is a dilated annulus, and a downsized annuloplasty ring shrinks that dilated annulus. For ventricular functional MR, as seen in that ACC-AHA recommendation, a chordal sparing mitral valve replacement is frequently indicated over a downsized annuloplasty ring. But again, this can depend on those tenting risk factors we talked about, in the degree of LV dilation and dysfunction, and other factors as well. How do surgeons prevent SAM when they're performing a repair? The question I would ask myself is, what is the risk factor for SAM and what can be done to address it? First off, the goal is to achieve the optimal coaptation length. Again, this is 4 to 10 millimeters, but really optimally it's 8 to 10 millimeters. Over that, you can have too much redundant tissue that predisposes to SAM. The second is to reduce posterior leaflet height. The goal for a surgeon is less than 15 millimeters. Remember, reducing the posterior leaflet height moves the coaptation point more posteriorly, which would actually increase that C-sep distance. To reduce the posterior leaflet height can be performed with neocords, resection, or even a sliding plasty. In regards to picking a ring, a large, true-sized ring or band is less likely to cause SAM than a downsized one. If a ring is undersized, that anterior mitral leaflet will not spread out, and that redundant tissue can predispose to SAM, and it also displaces that posterior mitral valve annulus more anteriorly, bringing it closer to the left ventricular outflow tract. Also, a partial ring is better in SAM prevention than a complete one. This is because during systole, the base of the anterior mitral leaflet actually moves posteriorly to increase the size of the LVOT, while the insertion of a complete ring at this area of the heart eliminates this movement, causing a narrower systolic LVOT diameter and favoring SAM. The surgeon can also further perform septal myectomy or edge-to-edge sutures to help prevent SAM. After the valve repair has been performed, what are things that need to be looked at in the post-bypass period? First and foremost, it's important to evaluate new or residual mitral regurgitation. Knowing these repair types that we discussed can actually inform your echocardiographic findings. For residual mitral regurgitation, the goal is trace or less MR. Now, mild MR may be acceptable in some cases, but we'll also measure that coaptation length and overlap to make sure it's 4 to 10 millimeters, which is the indicator for durable repair. The echocardiographic principles are the same for native valves or repaired valves, so you can use the same 2D echocardiography or Doppler echocardiography principles when evaluating for residual mitral regurgitation. It will be important to exclude iatrogenic mitral stenosis, that things weren't downsized too much and now you're dealing with some degree of mitral stenosis. You can assess this by using mean pressure gradient and or mitral valve area planimetry in both 2D and 3D. It would prompt me to further assess this if I saw a flow acceleration on the atrial side of the mitral valve, which would raise my suspicion for iatrogenic mitral stenosis. But the goal here is seeing a mean gradient of less than 5, which would be mild or less mitral stenosis. Gradients are dependent on a few different factors, so use caution if you're in AFib, if the patient is tachycardic, or if you have high or low cardiac output states, as these can all influence the transmitral gradient. It's important to evaluate for SAM after mitral valve repair. Some of the signs that can point us to this is seeing that systolic anterior leaflet motion of that anterior mitral leaflet, that last second flick into the left ventricular outflow tract. When looking at the jet, you can see an eccentric posteriorly directed jet. Now this creates that characteristic Y sign you can see where you have turbulence in the left ventricular outflow tract and also this posteriorly directed jet. The presence of elevated velocities and flow acceleration in that LVOT can also clue you into some degree of SAM and flow obstruction as well. Finally, when you use spectral Doppler, you may see this late peaking systolic dagger-shaped Doppler envelope to clue you in that there is some degree of dynamic flow obstruction. Keep in mind here that you would expect a posteriorly directed jet. If you see a central or anteriorly directed mitral regurgitant jet, just know that there might be mitral valve pathology that is separate from SAM altogether. What happens if you have SAM after you've come off pump for mitral valve repair surgery? There's a few steps you're going to walk through. Essentially, in the treatment of any SAM, you want to pursue medical treatment first. Give fluids to fill the heart. Slow the heart rate down, which also fills the heart. Stop inotropes and even potentially give esmolol. Increasing the afterload can help stent open that LVOT. In most cases, SAM will resolve with conservative management. And if you have an elevated gradient, this will normalize over weeks to months. So my thought here is do everything I can medically to improve it, and if I see an acceptable result, we're going to take that. However, if you still have significant SAM with significant LVOT obstruction despite optimizing medical management, it may warrant re-repair. There are a couple re-repair strategies if you have SAM after you come off pump. A lot of these are based on trying to move that coaptation line more and more posteriorly. This would include upsizing that ring even more, performing a neocord or resection to reduce that posterior mitral leaflet height, and also even using an edge-to-edge stitch, also called an Alfieri stitch, to stitch that anterior and posterior leaflet together in the middle to help prevent that anterior leaflet from being drawn out into the left ventricular outflow tract. After evaluating the mitral valve, we'll look on to evaluate the left ventricular systolic function. We mentioned that you lose your pop-off valve of mitral regurgitation, so it can put a little bit more strain on the LV, so you want to reassess for any reduced left ventricular ejection fraction after the elimination of the MR. Also, we'll assess assess regional wall motion. There can be injury to the left circumflex artery due to the close proximity to the mitral valve annulus when surgeons are putting their repair sutures into that ring. So we could possibly see new regional wall motion abnormalities that would prompt us to go back on pump and perform an emergent bypass, redoing sutures, or either if it's later on going to the cath lab to seeing if this lesion can be stented. You can also use TEE to evaluate the left circumflex artery as well. You'll find it in short axis in the OR, put X-plane through it, and then you should be able to evaluate the patency of it in long axis. If you see a significant kink spot or flow acceleration, that could clue you off to an area of stenosis. We'll also assess a few other parts of the heart after any mitral valve surgery, and the first of which is assessing new or worsened aortic regurgitation. Remember, there can be suture damage to an aortic valve cusp due to the close proximity of it to the mitral valve anterior leaflet. Frequently, this is the left coronary cusp or non-coronary cusp that could be damaged or retracted because of a suture. We'll look at any degree of residual TR, especially if a concomitant repair was performed during surgery, and evaluate RV dysfunction as well after any bypass run. And lastly, we'll evaluate the left atrial appendage, as these are frequently clipped or ligated in mitral valve surgeries. So let's review a few key points that we're going to walk away from this episode with. The first of which is trying to remember what factors favor repair versus the factors that favor replacement. These are very clinically relevant and can frequently be used to inform surgical decision-making. Number 2, assess the mitral regurgitant mechanism to help guide repair options. Knowing the mechanism, location, and severity of the MR is important information to give to the surgeon to help them perform the optimal repair for the patient. And lastly, number 3, know your different mitral valve repair options, as these can inform and look different on your echocardiographic assessment post-bypass. All right, next episode, we're going to get a little bit away from the clinical side and a little bit more towards the academic side with episode 14, what is the best way to learn TEE and also pass the basic and advanced perioperative transesophageal echocardiography exam. So we're going to talk through a few different strategies. If I had to do it all over again, here is the exact system I would recommend to anyone to learn it as quickly and efficiently as possible. Here are our references. Thank you guys for watching. If you want more of this content, feel free to hit that subscribe button and it'll bring you episodes as we release them. Also, leave us a review. It does help us get this content out to more people. And also, if you want to follow us on social media or leave us comments, that's a way that we can all help learn from each other, share what you do at your own institution. But again, thank y'all for watching. See y'all next time.